All right, let's dive right in. Today, we're not just flipping through a textbook, we are running a code. We're going to walk step by step through a cardiac crisis, a case study that's really designed to put your clinical judgment to the test when every second counts. Okay, picture this. You're in the room. The monitor is screaming, the patient's stats are dropping. This isn't just some question on a test. This is a real-time crisis unfolding right in front of you. So what's your first move? Let's break it down.
So that's the scene. In the middle of all that chaos, our number one job is to do a super fast, super focused assessment. We've got to gather those critical clues that are going to guide every single decision we make from here on out.
Your patient is showing you a classic, and I mean incredibly dangerous set of symptoms. In the world of ACLS, a heart rate over 150 is a huge red flag for stability. And think about it, right? The low blood pressure, the dizziness, the trouble breathing, they're not separate problems. They're all because the heart is beating so fast it can't actually pump any blood. The body is literally starving for oxygen. This is the textbook definition of an unstable patient.
Okay, so we've seen the outside signs of this crisis. Now we've got to put on our detective hats. We need to look inside, decode the electrical signals coming from the heart and the chemical clues in the blood to figure out what in the world is going on.
Before you can ever spot what's wrong, you have to know what right looks like, inside and out. And this, right here, is a beautiful, normal sinus rhythm. You see that perfect little P wave before every QRS? That means every beat is starting right where it should. It's predictable, it's efficient. This is our gold standard. And then, there's our patient. This is a totally different story. Look at that. Where are the P waves? And those QRS complexes are wide, they're bizarre, and the rate, it's terrifyingly fast. This, my friends, is ventricular tachycardia, VTach. The bottom of the heart is just firing off on its own, completely chaotically. This rhythm cannot pump blood, which is exactly why our patient is crashing.
So the ECG confirms our worst fears about the rhythm, but it doesn't tell us why it's happening. Is it a massive electrolyte imbalance? Some kind of metabolic disaster? The next step is hitting the blood work. So what are the absolute essential labs you need to draw, like yesterday?
We're hunting for the root cause here. You see a low pH and a low bicarb? You should be thinking metabolic acidosis, which can totally wreck the heart's electrical system. And when we talk arrhythmias, potassium is king. I mean it. Even a tiny shift outside that 3.5 to 5.0 range can trigger deadly rhythms, just like the VTach we're seeing. And finally, we've got to get a baseline aPTT. Why? Because if this whole thing is caused by a clot, and we need to start a heparin drip, we have to know our starting point to do it safely.
Okay, diagnosis is in. Unstable ventricular tachycardia. Now, we flip the switch from diagnosis to intervention. It is time to act, and we're going to follow the protocols that we know save lives.
The ACS algorithm is our roadmap. And the very first question, the one that changes everything is, stable or unstable? Well, our patient is clearly unstable, hypotensive, losing consciousness, so that means we skip the meds for now. The immediate go-to treatment is electricity, synchronized cardioversion. It's a controlled shock, we time it to the R wave, and the whole point is to hit the reset button on the heart's electrical system. If our patient were stable, we'd have time to try other stuff first, but not here, not now.
Okay, let's imagine for a second that our cardioversion worked and the patient is now stable. Or maybe they were stable to begin with. Now our next tool comes out of the box, pharmacology. We use antidysrhythmics to chemically control that heart rhythm and keep it from sliding back into VTach.
So according to the guidelines, procainamide is often your first choice for stable VTach. But you got to give it slowly, and you have to watch that blood pressure and the ECG like a hawk. If the pressure drops or the QRS gets wider, you stop the infusion, period. Lidocaine is another option, and here's a huge tip that trips people up on exams. The very first sign of toxicity is often neurological. We're talking numbness around the libs, sudden confusion. It's that classic reminder to always assess your patient, not just stare at the monitor.
A lot of the time, VTach is actually triggered by an underlying heart attack. So to treat the real cause, we need antithrombotics. Now, it's so important to know the difference. Think of it this way. Antiplatelets, like aspirin, make the platelets less sticky so they don't start to pile up. Anticoagulants, like heparin, stop the chemical reaction that forms the actual fibrin glue of a clot. In an emergency like this one, the patient's probably going to get both.
This number right here is your safety net. You have to know this. When a patient's on a heparin drip, we're not just guessing. We are constantly monitoring their aPTT, and we are aiming for this super specific window, 1.5 to 2 times whatever their baseline was. If you're too low, the drug isn't working and they could clot again. If you're too high, you risk a catastrophic bleed. This number is your guide.
Okay, so let's say we did it. We cardioverted the patient, the rhythm is stable, we have a pulse. Take one deep breath, because the crisis is not over. Now we start the really complex phase of post-arrest care, which is all about protecting the brain and the other organs.
After we get a pulse back, what we call ROSC, or return of spontaneous circulation, the body has been through a massive trauma. So our priorities totally shift. We're now trying to protect the brain from injury. We'll manage their blood pressure, put them on a ventilator, but a really key intervention is something called targeted temperature management, or TTM. We deliberately cool the patient down to slow their metabolism and protect the brain from swelling. And just as important, the rewarming has to be slow and controlled, like 1/4 to 1/2 degrees Celsius per hour, so we don't shock the system all over again.
So here's a scary thought. In our rush to save a life, sometimes our treatments can actually cause another huge problem. A patient can become toxic from the very drugs we're using to help. And this is where knowing the antidote is just as important as knowing the drug itself. This can be the final piece of the puzzle that saves a life.
Here are 2 you absolutely, positively have to have locked in your brain. For digoxin toxicity, which can cause all sorts of arrhythmias and gets way worse with low potassium, the antidote is digoxin immune fab, or Digibind. And for a Tylenol overdose, a common cause of liver failure, the reversal agent is acetylcysteine. Knowing these 2 cold can literally be the difference between life and death.
Whew, we have gone from crisis to stabilization to post-arrest care. So now, let's pull all of this together. Let's synthesize everything we've covered into the core principles that you can carry with you into any cardiac emergency.
Let's boil this whole thing down to the golden rules. First, treat the patient, not the monitor. Your assessment of stable versus unstable tells you what to do first. Second, know your algorithms cold, but also understand the why behind them. Why are you checking that potassium? Why are you titrating that heparin? Third, always be thinking one step ahead. Anticipate what could go wrong and be ready for it. And finally, none of this works if you're a one-person show. Clear, calm communication is the glue that holds a great team together.
And hey, don't just take my word for it. This isn't just a nice idea. It's written right into the ACLS guidelines. The best algorithm on earth is useless without a team that can actually pull it off. Everyone, from the person running the code, to the person pushing meds, to the person writing it all down, has a vital role. It's that synergy that saves lives.
So in the end, we've got the protocols, we have the data, we have all this amazing technology, and they are absolutely essential guides. But when the pressure is at its absolute peak and a life is hanging in the balance, what is that thing, that human factor that elevates a group of people into a truly life-saving team? That's the question we should all be trying to answer.